Symptoms and signs. The typical presenting symptoms of acute pancreatitis are abdominal pain, mainly in the epigastrium, and elevated pancreatic enzymes, because of the inflammatory process in the pancreas, which are obvious in blood and urine tests. The clinical indications are variable and may present as mild, self-limiting abdominal discomfort, or at the other extreme may present with an acute abdomen and shock. Nausea and vomiting occurs in 85% of patients. Acute pancreatitis may also present without abdominal pain, but with symptoms of respiratory failure, confusion, or coma. Low to moderate fever is not uncommon. Tachycardia, hypotension, mild jaundice, and pleural effusion may also be present. In pancreatitis of biliary origin or of obstructive nature, the pain is often described as sharp stabbing, which radiates to the back, whereas the pain of toxicologic and metabolic origin is often described as dull and generalized. Abdominal examination reveals epigastric tenderness with guarding, rigidity, and decreased bowel movement. In severe cases where retroperitoneal bleeding occurs, Gray-Turner sign, which is ecchymosis at the flanks, and Cullen's sign, periumbilical ecchymosis, may present. Ecchymosis is discoloration of the skin resulting from bleeding underneath. Chronic pancreatitis. Unlike acute pancreatitis, which causes abdominal pain that radiates to the back, patient with chronic pancreatitis may remain asymptomatic for a long period of time, or at times may require hospitalization due to unrelenting abdominal pain. Histologically, predominant cells in the inflammatory process of acute pancreatitis are neutrophils, while chronic pancreatitis has more mononuclear infiltrates. Evaluation. Diagnosis of pancreatitis is made on the basis of the following criteria: amylase or lipase level, which is almost 3 times above the normal limit. Abdominal imaging consistent with acute pancreatitis. Acute pancreatitis should be suspected whenever there are abnormalities which suggest biliary cholestasis, hypercalcemia, and hyperlipidemia. Abdominal ultrasound is recommended in all patients to assess biliary duct dilation or the presence of stones. Chest X-ray is usually taken to evaluate pleural effusion, which is an indication of the severity of the disease, but non-specific. Whenever the diagnosis is equivocal, a CT with IV contrast is obtained to establish or rule out the diagnosis. If none of the above methods work, MRCP, which means magnetic resonance cholangiopancreatography, or endoscopic ultrasound, is required for further evaluation. ERCP, which means endoscopic retrograde cholangiopancreatography, can also be performed in some cases. Management. Management for acute pancreatitis includes IV fluid therapy. Lactated Ringer solution is recommended with an initial bolus of 15 to 20 milliliters per kilogram, and later on at a rate of 3 milliliters per kilogram per hour for the first 24 hours, provided there are no contraindications. Blood urea nitrogen, hematocrit, and urine output should be monitored every 4 to 6 hours for the first 24 hours to adjust fluid rate. Nil by mouth until abdominal pain, nausea, and vomiting improve. In cases of mild pancreatitis, it's safe to feed the patient. Meals should be low in fat and should be soft. In severe cases, nasojejunal feeding is also done. Prophylactic antibiotics are not needed. If infection is suspected, empirical antibiotics should be given until culture's results are back. In pancreatitis with gallstones, early cholecystectomy is highly recommended. Early ERCP is important in cases with concurrent cholangitis and biliary obstruction. In the presence of hypertriglyceridemia, its level should be brought down to less than 500 milligrams per deciliter using apheresis and insulin drip with or without glucose. Differential diagnosis includes peptic ulcer disease, cholangitis, cholecystitis, bowel perforation, bowel obstruction, mesenteric ischemia, acute hepatitis, diabetic ketoacidosis, basilar pneumonia, myocardial infarction, renal colic, and aortic dissection. Complications: sepsis, ARDS, hemorrhagic pancreatitis, necrotic pancreatitis, renal failure, pseudocysts, infected pancreatic necrosis, and pancreatic abscess. Management of complications. Parapancreatic fluid usually resolves spontaneously with treatment, in most cases, but it can form pseudocysts in less than 9% of patients. Most of the cysts require nothing more than observation and follow-up using CT or MRI. Drainage is only considered in symptomatic or infected cases. endoscopic approach is preferred more than percutaneous approach. Infected necrotic tissue is diagnosed whenever there are gas bubbles on imaging and CT-guided percutaneous aspiration culture. Operative necrosectomy is only indicated in patients who keep deteriorating even with antibiotics. Less invasive modalities are indicated initially, such as endoscopic and percutaneous drainage, while surgical debridement is reserved in unsuccessful cases. Prognosis. Mortality of acute pancreatitis is approximately 1 to 2%. However, severe acute pancreatitis carries a much higher mortality rate. Assessment is important to determine the level of risk and care. Bedside index of severity in acute pancreatitis is the most recent addition to the list of clinical prediction scale that have been developed.